Recording in progress.
Bismillahirrahmanirrahim. Good morning to everyone. First of all, I want to thank all the organizers of WBMT for inviting me on this session on transfusion services for hematopoietic stem cell in the centers. I would start off by saying that blood transfusion therapy, there can be different paradigms of the areas around the availability of the blood transfusion for hematopoietic stem cell and rather whole of the blood transfusion for other sectors as well. The most applicable would be this paradigm where the cost effectiveness availability takes precedence over the clinical efficacy and safety of the products. And the reason for this is simply because we have been having, since our formulation, since the long time, demand-driven, fragmented, poorly regulated blood transfusion services, which is being extended by different sectors like public, military, NGO, and private sector. Roughly, we collect about 3 million blood donations annually, and these are 650 of the blood banks collecting these are registered. However, there are unknown number of small labs and hospitals which provide unregulated and undocumented services. These practices are fraught with a lot of corrupt practices, as well as there are many HR issues which compromises the safety and other areas of the blood transfusion. However, the reforms were started back in 2008 with the help of the German government, and Ministry of Health established the Blood Transfusion Act and National Provincial Services for as independent and at provincial levels as independent entities. However, this initiative had a setback when 18th Amendment legislation was done, where education and health became a provincial sector, and then the federal level was reduced to advisory capacity and communication and coordination only. However, progress has been made, and 11 regional blood centers, which are supposed to provide service to the dependent hospital blood bank and public sectors, have become operational, and 10 are under construction, and total 30 are to be constructed. Now, these are operating in different cities and different model of the service, including a private-public partnership as delivering the service and running their centers. If I'll draw your attention to WHO Action Framework on universal access to safe and effective and quality assured products for 2020, I've highlighted these areas and benchmarked our country performance against these areas. Green are where we have made significant progress, while the gray text highlights those areas which are still not yielded the results and not achieved that level which is desired. And red are those areas which are absolutely sort of a blind spot, and we have not made any progress in those areas. And those are very critical and essential areas. We do have a properly structured, as I highlighted in the previous slide, but they are not yet sustainable. Similarly, regulatory capacity is still not able to ensure quality and safety of blood. We have functioning blood services, but not efficiently managed. We have no progress on the clinical side of blood patient management to optimize transfusion practice, surveillance, hemovigilance, or accurate and comprehensive data collection system. Partnership and collaboration and information exchange remains very, very non-existent. It is totally non-existent at all levels. It is a well-known fact that nationally coordinated and regulatory blood system goes a far way to deliver optimum services to the patient. And this blood regulatory system would promote a neat distribution or division of the blood transfusion services, where the supplier would ensure at blood transfusion centers collection of blood from volunteer donors, testing them, processing them, and then supplying the same to hospital blood bank. And hospital blood bank would be concerned with receiving patient sample, cross-matching, interacting with the clinical transfusion, clinical disciplines, and use the tools like hospital transfusion committee in order to achieve the desired results. So these are blood transfusion centers. They are obviously, as I highlighted previously, the paradigms remains again cost effectiveness and availability and safety remains a priority down on the list. Here, the clinical services are also more concerned with cost effectiveness, to some extent clinical efficacy, and hardly concerned about the safety. These services can be delivered by state itself that takes the responsibility of regulation as well as delivery of the services, or state can delegate the responsibility to credible organization and regulate the services itself, just like it happens in USA. However, whatever the model it is the most important thing is to have coordination and collaboration and close liaison among these two in order to work on these areas. This is a key to improving the services from all aspects. So with this background that I simply highlighted to you, I can safely say that universal access to safe and effective blood components remains elusive for majority of clinical services and patients in the country, including the hematopoietic stem cell transplantation. So the question is how to access this safe and effective blood transfusion. I would keep, I have highlighted 4 or 5 points for achieving that. One would be to look at evidence-based cost-effective interventions which over the time have been made available and can be effectively utilized in order to reduce the cost and increase the safety of product. Collaboration among the blood suppliers and the users and among different stakeholders, the communication among the different stakeholders is essential in order to not only implement the evidence-based cost-effective intervention, but also very important in our setting for resource sharing, optimization, and resource management. Many times resources are there because of the mismanagement of the resources. The patients would not get the benefit which we can probably provide them with less of the effort and more cost effectively. Probably clinical governance and leadership, if takes hold and is practiced properly, then that can push the suppliers and the blood banking sector to actually meet the needs and priority areas. So I think that is one of those important areas where a lot of work can actually make a lot of impact. We do have different epidemiology of the diseases which has been adversely impacting the availability of the blood, especially the volunteer donors. But however, I could recommend that we can even we can work to find opportunities and capitalize on these adversaries that we are facing. For example, 1/4 of the national annual blood collected is transfused to thalassemia patients, and they are mostly poorly screened, and these collections are not made in triple bag, resulting in wastage of platelet and plasma. In this situation, the NGOs and VDOs have become become active, and these recruit volunteer donors, but mostly for thalassemia patients, and then at the cost of availability of volunteer blood for situations like obstetrical hemorrhage emergencies, pediatric, and hematopoietic stem cell use. So in that situation, as I said, that probably we can manage these resources, and this poorly screened blood can be properly screened, and those which is being collected in single containers can be collected in triple bags, and that will prevent the wastage of blood and platelets and plasma that can be made available, especially to hematopoietic stem cell patients. And also since these structures exist, they can also be sensitized to not only work for volunteer donors, donations for thalassemics, but also for other kind of patients. Now, I'll highlight few of the interventions that can cost effectively make available those labile products, which otherwise are become very expensive if they are salvaged or if they are obtained from apheresis system. For example, now platelet whole blood leukofiltration has been advanced to that level that leukofiltration of all the products can happen, and compared to, as contrast to previously where the platelets were used to get wasted because they were liquid filters would not spare the platelets. Similarly, there is another assembly that I'm showing here where all three components can be leukofiltered, and the red cells collected can also have can be added to the additive solution in order to increase their shelf life and flow properties. And similarly, the platelets can also be leukofiltered and collected in a container of different plasticizers, which can actually increase their shelf life. So this sort of assembly can actually produce leukofiltered products, which are essentially needed for hematopoietic stem cells patients, and that can increase the cost effectiveness and replace the apheresis platelets, which are difficult to come and very expensive to afford in this setting. Similarly, the leukofiltered products can also be made not only here, this is pre-storage where the shelf life is retained. Here, this is after storage or on demand, where the platelets can be filtered or red cell can be filtered. However, if they are done in the open system, that will reduce the shelf life, but they can also be, intervention can also be planned where a sterile connection device can be used in order to make products, leukofilter the products by not compromising their shelf life. The bacterial sepsis has been in forefront for the last decade or so, and finally now the regulation exists whereby the blood transfusion services have to employ the methods to either detect or minimize or inactivate the bacteria, especially in the platelet components. One of the ways that has been introduced was to divert initial 10 ml collection of the donated blood in a diversion pouch, which can also be used later for bacterial detection and other testing. And this assembly combined with meticulous cleaning of phlebotomy site can reduce bacterial contamination to as much as 70%. And these are the type of interventions that should be universally adopted by countries like us in order to make the product safe and increase their and make them cost effective. This is alternate to apheresis plated, this concept that I already highlighted, whereby the random donor platelets, which are available in ample quantity and being wasted in our country especially, can be pooled, and then they can be leukoreduced, and then they can be bacterial tested through by obtaining a sample on this bacterial pouch, and that the cost can be lowered to half of what apheresis platelets, and availability can be ensured. Now coming to the other important aspect which of safety which concerns the clinical services. Our provincial legislation covers the hemovigilance very comprehensively, and it mandates that to increase the safety and efficacy and efficiency of blood transfusion, hemovigilance program should ensure the traceability of blood products from the donors to recipient. And that actually states this gives an explicit need for blood establishment computer software, use of technology that can ensure both the donor and recipient hemovigilance, which is mandated in the legislation, and all the blood banks, blood transfusion centers, and clinical services are supposed to abide by them. So these are clinical case reporting in order to collect and assess information of undesirable side effects so that we can learn lessons and prevent their occurrence and recurrence. And this cannot happen without clinical services taking proactive role in collecting this data. And this can only exist, and the steps that usually it involves are agreeing on the definitions, then observing the side effects and adverse effects, recording them as structured and systematic way, reporting them to central office, and analyzing the data, and then evaluation by the experts, and will make appropriate recommendations, and finally those recommendations are implemented, and then they are monitored in order to see the effectiveness of the measures. The information management system, as I highlighted, the hemovigilance cannot take place without blood establishment computer software and use of technology. And therefore, International Consortium for Commonality in Blood Bank has been providing the guidance and technical documents whereby there is agreement on the terminology and definition, reference tables have been made, and data structures are advised, and delivery mechanisms are discussed, and finally the labels that would contain the information that can be universally read. These technical specifications are called International Society of Blood Transfusion 128, and that specifies standards for not only blood but also hematopoietic stem cells. And that's a sort of final label that is generated on all sort of blood and tissue products in order to have traceability, assist hemovigilance, as well as increase the safety of the blood products, and compile the data. So if this is one of the interventions which can go a long way in ensuring the safety of the products. So in conclusion, I can say that there are many problems in accessing safe and effective blood transfusion support for hematopoietic stem cell, which can be solved by resource management, cooperation, coordination between different stakeholders, even in fragmented landscape like in our countries. Technologies, interventions, and evidences are available that can be utilized to make safe, effective, cost-effective blood products viable for hematopoietic stem cell transplant in the country. Clinical leadership and governance can be the starting point to achieve the desired in this area to ease the burden. With this, I thank you very much for your patient listening.